thanks, Dr. Saad, for this introduction. I have a great honor to join such a wonderful, valuable, informative course. And it's my great pleasure to introduce Dr. Samir Elansary, inshallah, for his first talk. بإذن الله. You can proceed, Dr. Samir. Share screen, please.
بسم الله الرحمن الرحيم. At first, thanks for Dr. Khalda for this nice introduction, and a great pleasure for me to introduce me really. I am trying to sharing now the presentations. Okay, Dr. Saad, it appeared now. Dr. Khalda.
We can.
I am going today to speak. Good evening, first for my colleague. Good evening, our attendees. Today I am going to speak about ventilation teaching, some teaching points I select for RDS and for management of any patient on ventilator in general. At the start, I want to stress on some points which is very important, and every intensivist must be oriented by it. What is the difference between the peak inspiratory pressure and the plateau pressure? Of course, it is very important. Peak inspiratory pressure is a dynamic one which transmits the trans-airway resistance, even resistance in the tube or in the circuit or secretions, the kinking of tube and right bronchus. Of course, this value will be increased. On the other hand, the plateau pressure reflects the transthoracic pressure or the compliance of the lung and chest wall. And there is a difference between the peak inspiratory pressure and plateau pressure, and the difference reflects the airway resistance through the airway passage and through the endotracheal. This is a curve demonstrating peak inspiratory pressure again, and then the drop, the inspiration drop. And so this is a dynamic during flow and reflects the dynamic compliance, in contrast to plateau pressure reflects the static compliance, because the airway stop here and measuring the plateau pressure. Don't exceed the peak inspiratory pressure in general, more than 40 centimeter water, plateau pressure more than 30 centimeter water. Of course, the normal resistance is about 10 centimeter water per liter per second. Compliance of the lung in the range from 50 to 100 ml per centimeter water. I wanted to stress on one point here, very important. What is the difference between alveolar pressure and pleural pressure? And so the difference between the two reflecting the driving pressure, which is very important. Now we depend now on driving pressure, not on plateau pressure. And so try to keep the difference between the alveolar pressure or the plateau pressure in the range of 15 to 18 centimeter water. What is the pleural pressure reflected through measuring Y esophageal pressure through catheter introduced through esophagus? Of course, most of us not measuring esophageal pressure, but this is not meaning there is no pleural pressure. No, there is pleural pressure, especially in patients exhibiting some chest wall low compliance, like obese patient, a patient with some scar on the chest wall or problem on the chest wall will reflect a high pleural pressure or high esophageal pressure. And so at that time, you can increase your plateau pressure more than 30 centimeter water, as we will see in some examples. And so the transpulmonary pressure or the pressure inside the alveolus minus the pressure outside the alveolus, which is important for me as intensivist to measure it and stress on it. The transpulmonary pressure, which is the cause of ventilator-induced lung injury. If transpulmonary pressure or driving pressure increase, it will cause, of course, lung injury or trauma to the lung. Driving pressure is very important and used to distend the lung versus chest wall, and so we have to measure it for evaluating of safe pressure for ventilated patient. Flow pressure, of course, equal peak pressure minus plateau pressure, which reflects the airway resistance. If the peak pressure 40 centimeter water, plateau 30, 40 is equal to 10 centimeter water, this represents the resistance through the airway. If increase, it is an alarm for you to suspect some occlusion in your airway passages such as mucus, kinking, small tube, tube in one bronchus, and so on. Descending pressure, which equal plateau minus base pressure or minus PEEP, and also in addition minus the esophageal pressure or pleural pressure. And so we depend now again on driving pressure, which equal plateau pressure minus the base pressure, not the plateau pressure to avoid lung injury. Driving pressure normally try to keep it less than 15, 18 centimeter water. Peak esophageal pressure minus base esophageal pressure reflects the pressure to distance chest wall. If there is any problem in chest wall, the peak esophageal pressure or the peak pleural pressure will be high, of course. Transpleural pressure again equal plateau minus the peak value minus the peak esophageal pressure minus the base esophageal pressure. High peak esophageal pressure we will see in patient exhibiting chest wall problems like scar chest or bender around the chest as post burn or post plastic surgery and fibrotic chest wall and so on. In cases of pulmonary edema, it will increase the plateau pressure, not the peak pressure. Safe to increase the driving pressure, of course, in cases of chest wall problems as in RDS or stiff chest, but unsafe to increase it in stiff lung. And so avoid high driving pressure or high driving pressure in stiff lung, but you can increase in stiff chest. Esophageal pressure or pleural pressure reflect chest wall problems. Also, in chest wall problems, you can increase the PEEP, no problem, but don't increase in lung stiffness. Don't increase PEEP and lung stiffness because it will be reflected on airway pressure and subjects the patient to barotrauma. How to measure plateau pressure? It is just holding the inspiratory flow. If you hold the expiratory flow, you will get the intrinsic PEEP or auto PEEP, which reflects the hyperdynamic hyperinflation, such as in cases of COPD or in patient with low expiratory time and so on. Peak pressure equal stretching pressure plus flow resistance. Again, peak pressure equal, in other words, plateau pressure plus flow resistance. Stretching pressure will equal plateau pressure. Stop flow to get the plateau pressure. Chest wall problems again will cause increase in esophageal pressure, will increase the pleural pressure, and it is safe to increase the transpulmonary pressure or driving pressure in chest wall problems. I repeat this item always in my lectures because it is very important. Plateau pressure could be increased to even 40 centimeter water in such patient with chest wall problems with either tidal volume or with PEEP. Lung injury occur in always in healthy regions of the lung, not in the diseased one. Lung injury, various varieties may be from overstretch, and so avoid stretching the alveoli through high ambu-bagging and so on, and also through tidal volume. Tidal volume even cause so stress and strain causing overstretch or injury to the lung. Atelectasis also, and so we apply sometimes the recruit maneuvers to avoid atelectasis or apply PEEP. Shearing effect also very important. This is just inflation and deflation of the alveoli. This one, especially for RDS alveoli, causes some shearing effect and causes lung injury and more lung injury. Overdistension injury is regional always, tidal volume diverted from the injury unit to overdistend the health units. In setting of a normal or near normal chest wall compliance and even with a normal tidal volume, regional overdistension is likely to occur if plateau pressure exceeding 30 to 35 centimeter water, and now if exceeding the driving pressure, which is 15 to 18 centimeter water. Stress and strain, very important. Both are important to avoid lung injury. Both stress, maximal stretch, and strain, tidal stretch, clearly involved in volume-induced lung injury, evolving in clinical goals. Limit transpulmonary plateau pressure to less than 30, or your tidal volume not exceeding 5 to 7 milli per kg from ideal body weight, ideal lung size, ideal body weight, not the actual weight. We now, many trials now try to refer the tidal volume to the functional residual capacity, not to the ideal body weight, and also even to the compliance of the lung and chest wall, and even Amato established that driving pressure must be less than 15 to 18 centimeter water. Driving pressure, again, which equal plateau minus PEEP, allow scaling of tidal volume to functional lung size as reflected in compliance rather than ideal lung size, which is referred to ideal body weight. Goal 15 to 18 centimeters. I will start now some cases, discussion to some cases, and I will answer these cases in short to save time. The first case, breast X is baseline. This one is a baseline, and these are colors of the ventilator screen. We have to be oriented with it. We have 3 colors, curves, pressure time, flow time, volume time, and in addition, esophageal caster to reflect the pleural pressure time scalar wave, and very important really to reflect the chest wall problems. In this basic one, there is no problem with the flow or tidal volume or with the pressure. But in A and B and C and D, some problems occur. The peak pressure start to increase on all these A, B, C, D, in all these patients. And the plateau pressure started to increase here in B and C only. Which one of these curves or scalar curve go with or coincide with pulmonary edema? Which patient who exhibiting pulmonary edema in these 4 patients, if you have to look? If we look to D, there is an increase in flow, and so I think this increased the peak pressure, but the plateau pressure is still the same. And so here, the peak pressure is increased, but plateau pressure is still normal. In C here, I can see peak pressure increased and the plateau pressure increased, but due to increase in the esophageal or pleural pressure, which increasing the peak and plateau pressure. If I look to B, there is increase in peak and the plateau pressure, and I think this patient exhibiting pulmonary edema or suffering from pulmonary edema, which increased both plateau and peak pressure. And so from the scalar curve, you can diagnose the problem in your patient, and this is very important to be oriented with the feedback of monitors, which give you a good and valuable information about your patient. Another patient, massive obese patient, he is in the ICU requiring mechanical ventilatory support for his aspiration, and so he developed chemical pneumonitis or Mendelssohn syndrome. His tidal volume is 6 ml per kg, ideal body weight, but his plateau pressure is 37 centimeters. CO2, arterial CO2 55 millimeter mercury and the pH 7.3. Esophageal balloon inserted and reflected the pressure or pleural pressure at that time. It is not written here, about 20 centimeter water here. What should be done for this patient with tidal volume? I have to reduce the tidal volume or maintaining the tidal volume, or the tidal volume must be increased to improve the pH. As you know from the protective strategy, 7.3 pH is accepted for this patient. I attached here to 6 ml per kg ideal body weight. Carbon dioxide may be increased, but it is a permissive hypercapnia in such patient with obese patient. Esophageal castor here reflected a high chest wall problems, or chest wall compliance is low and the reflecting pressure of 20 centimeter water. And so if I subtract 20 centimeter from the plateau pressure, which is 37 centimeter, which appeared high, it will be 20 centimeter, which is optimum for these patients, and it is accepted plateau pressure. And so keep the tidal volume of these patients the same, no need to decrease or increasing it. And always putting in your consideration the obese patient excepting some problem, which is a high pleural pressure due to obesity. And so we can increase the plateau pressure not only to 30 centimeter water, but maybe more than 30 centimeter water according to pleural pressure value. Another case, a patient with severe COPD has been placed on mechanical ventilation, volume assist control for respiratory support, initial tidal volume 6 ml per kg, rate 30. Over the next several hours, however, the CO2 has climbed up from 36 to 58 millimeter mercury, and the air ventilator graphical display has changed. What is one thing to change that would help? If you look to the scalar waves here, the flow time and volume time and airway pressure time, you will detect the problem. And I think the problem here, COPD patient with rising carbon dioxide pressure. What is the cause here of this problem? You can see here from the flow scalar wave, the expiratory flow is not going to the baseline at the end of expiration. And so there is hyperdynamic hyperinflation in this patient due to COPD. And so we the only solving the problem here, we have to either decrease the minute volume, tidal volume, or respiratory rate, or apply external PEEP, or we can give bronchodilator. And so we decrease the respiratory rate better here in such a patient. Don't apply PEEP because it is a COPD patient and he will not tolerate high airway pressure. Also, this patient, as we see here, tidal volume, of course, the low intrinsic peak or hyperdynamic inflation of the chest will increase the peak and airway pressure and the plateau pressure. We increase the peak, both peak and the plateau pressure will be increased, and the tidal volume will go down from this O to B, which explained here from the flow volume curve, not going back to the baseline. And so we decrease the rate. We not apply PEEP because it is suffering from COPD, high airway pressure, not advisable. Also, we can give bronchodilators for such patients, no problem. This also scalar curves show the effect of intrinsic PEEP in both volume assisted controlled ventilation and the pressure assisted controlled ventilation. If you look to volume assisted controlled ventilation here, you will see the volume is fixed, no problem with the volume. The volume, but the changes which will occur if the patient developed intrinsic PEEP, the airway pressure, the plateau pressure, and the peak pressure will increase, as we see here from the pressure time scalar curve. We see it is increased more than here. And so in contrast to pressure assisted control, pressure is fixed, and so the changes will affect the volume of the patient received from the ventilator. And so we see here if the intrinsic PEEP occur and the pressure, the volume will be decreased here if we compare it with the previous volume, decreasing in volume. And so the effect of intrinsic PEEP on volume assisted control ventilation will increase the airway pressure and plateau pressure, and the X effect on pressure assisted control ventilation, it will decrease the tidal volume. This is another scalar wave to demonstrate to you how you can diagnose the intrinsic PEEP or hyperdynamic hyperinflation. And clinically, you can you can diagnose the hyperdynamic hyperinflation. You will find the airway pressure on the scalar wave increasing and the plateau pressure increasing and the CO2 increasing in in ABG results. And also the chest wall will be rising. If you disconnect the endotracheal tube from the circuit, you will find a gush of air coming out. And sometimes we making this maneuver in COPD patient every now and then, disconnect the ventilator and press on the chest to expire the retaining gas if we suspect intrinsic PEEP or intrinsic airway remaining in the chest. Also, we can see here the effect of intrinsic PEEP on inspiratory threshold load. It increasing the inspiratory threshold, of course, as we see here. If this patient triggering ventilator and if this ventilator acting on the assisting mood, the patient will find very difficult in initiating the ventilator. The inspiratory effort will be increased, as you see here. Inspiratory effort will go down to try to trigger the ventilator. And so, at such a situation, we can apply PEEP. If we apply PEEP 5 centimeter water, as we see here, the effort will be less. The esophageal pressure will becoming less, and this is a good solving for the problem for intrinsic PEEP. Effort also can affect the transpulmonary pressures, and you have to increase the transpulmonary pressure in cases of severe effort. As you see here, effort will diminish the airway pressure, and so we have to increase the airway pressure to maintain the tidal volume for such patients. Another case here, compliance worsens between A and B, between these scalar waves and between this. As we see here, the compliance becoming worse here in this patient here. Compliance decrease, the flow decrease, and also the tidal volume go down. And so the patient started to compensate by increasing the airway pressure, and the tidal volume resolved again and going up. What is the mood of this maneuver done by, what is the type, what is the mood of ventilator in such situations? If it is proportional assist or SIMV or pressure support or pressure regulated volume control or volume support. In proportional support is the ventilator increasing its tidal volume and flow and so on according to the increasing of flow of the patient. If the patient increasing the flow, the ventilator respond and increasing the flow. In SIMV, the pressure is fixed and also the volume is fixed. Pressure support also, the pressure is fixed. In pressure, in volume support, there is some spontaneous activity, but in pressure regulated volume control, it is typical for such a patient which increase the airway pressure to compensate for low tidal volume. As you know, in such mode, there is a feedback mechanism between the ventilator and the testing the previous tidal volume. If the previous tidal volume is decreased, the ventilator compensates by increasing the flow to compensate for tidal volume or by increasing the pressure. Another patient here, patient with RDS, has chest CT scan compared to the lower half of the lung-dependent regions. The upper half of the lung non-dependent region during positive pressure press will be. We see here the lung CT scan, the lower lung is consolidated, severe RDS, the upper lung is not consolidated, and there is remaining alveoli for ventilating alveoli. If this lung, if we look here, have a higher regional inspiratory plateau pressure but comparable regional tidal volume, both lungs exhibiting comparable same tidal volume but higher regional inspiratory plateau pressure in the upper half, or have a lower regional plateau pressure but comparable regional tidal volume, or have a comparable regional plateau pressure but higher regional tidal volume, or have a comparable regional plateau pressure and regional tidal volume. If there is difference in pressure here between the upper half and lower half, if the tidal volume here is more than the lower one, of course the pressure will be the same in all the lung. And so there is a comparable regional plateau pressure throughout the lung, diseased lung or non-diseased lung. But the normal lung or to some extent healthy lung will exhibiting a high tidal volume. So here, a good high tidal volume, and in the lower half, the tidal volume is very low, but the pressure is comparable in both sides. And so have a comparable regional plateau, but higher regional tidal volume. Another case, 50 years old, developed severe acute respiratory distress syndrome. He is receiving volume assisted controlled ventilation with a tidal volume of 712 ml per kg idle body weight, high tidal volume, as you see, respiratory rate 14 breaths per minute, airway pressure beep 10 centimeter water, and FI 2.6 on the maximum. His plateau pressure is 38 centimeter water, pH 7.38, carbon dioxide 44, and arterial oxygen pressure 68 millimeter mercury. You elected to follow the RDS network protocol and reduce his tidal volume to 6 ml per kg idle volume in a stepwise fashion while maintaining an acceptable arterial CO and the pH with an accompanying increase in respiratory. According to recent clinical trial results, these changes which you make after decreasing the tidal volume to 6 ml per kg, which is the protocol for protective lung, according to recent clinical trial results, these changes are likely to reduce his mortality risk along with up to 48, 72 hours of improving lung compliance and oxygenation, worsening lung compliance and oxygenation, improving lung compliance but no effect on oxygenation, no effect on compliance or oxygenation. If you follow this, as we see here, previously the patient on high ventilatory state, he may be subjected to barotrauma and so on. And the ABG, reflected ABG, accepted to some extent, and we are happy with its value. But if we attach it to RDS network, we have to decrease the tidal volume, and so the patient will be hypercapnic, will be more acidotic, will be hypoxic, and so on. Which one you prefer? The previous one or the new trend or the new adjustment on your ventilator? And which one will lead to these items? I think it will worsening the lung compliance and oxygenation. And so the protective lung strategy, which if we follow it for the patient with RDS, for it will give us a bad result of oxygenation and compliance within 24 hours, 48 hours, even up to 78 hours. The patient will exhibiting more hypercapnia, more acidosis, more hypoxemia, and so on. But from the mortality point of view, it gives more better prognosis and decreasing the mortality. And so if you follow the RDS network protocol, you will not satisfied with the ABG results. But if you not follow, the result will be very attractive, oxygenation high, pH okay, but your patient will be subjected to barotrauma and volume-induced lung injury, and the mortality will be high. Another patient here, a patient has the ventilator adjusted from left to the right panel to improve the comfort. What is the adjustment and was it successful adjustment? This patient, as you know here in the curve, in the pressure, in the scalar curve, pressure time curve, she is cusping or going down or scalloping of the curve. This meaning air hunger or the air flow is not sufficient. And so he is shifted to pressure support to improve his airway flow, to adjust the airway flow, and so the cusping or indent in the curve is decreasing and going up. And so it is more better, always pressure control or pressure control ventilation, more comfortable for the patient. Some intensivists prefer to use recruit maneuver to avoid atelectasis, although it is a grade 2 now and not so advisable. But if you use recruit maneuver, by either airway pressure release ventilation with ample bagging, with high SPAP, with high PEEP, and so on. You have to follow your recruit maneuver with PEEP application. Otherwise, your recruit maneuver invaluable and do nothing. Always select your PEEP and your FI2 according to scientific basis. You can depend on visual evaluation like CT, usually improving area of radiation, or electric impedance tomography to demonstrate the area of high compliance, increased or no. Also with ultrasound to detect the improving area with the PEEP. And so you have to select the either. Also mechanical pressure volume curve based compliance, or esophageal pressure or stress index from the pressure time curve. Or you can also, for gas exchange on PEEP and FI2 tables to select the ideal PEEP in comparison with, which coincide with the ideal FI2. Meta-analysis of 3 trials emphasize or support PEEP over FI2 in moderate and severe RDS, reverse in mild RDS. Patient ventilator synchrony is very important, and so try to optimize the airway flow to avoid stacking of breaths. Also adjust the triggering effort must be optimal for the patients, good sedation, and so on. Synchrony improve oxygenation and decrease the ventilator days. This some of the volume of ventilator loops, and I want to just mention some of it because it is very important and most of us neglect it and depend only on the scalar waves. You have to be oriented with pressure volume loop and what is its component as we see here. You can see the loop here is almost square in pressure controlled and pressure support. Because the pressure limiting constant, as you see here, pressure limiting constant, this is the peak inspiratory pressure, this is inspiration, going up to the dynamic, this point reflects the dynamic compliance, and this is the expiration. Of course, inspiratory curve depend on resistance of the airway and also resistance of work of breathing, and the expiratory wave depend on the elastance of the respiratory. This is inspiration, expiration. We have to be oriented with its normal position and normal size. This is a volume pressure loop. We can see lung compliance changing here. In RDS, you will see if you use according to mood, which you use in your ventilator, and pressure controlled ventilation, fixes the pressure, the volume will be changed according to changes in the compliance. If the patient suffering from RDS and low volume, the curve will be shifted downward and maybe shifted to right, but due to preset peak inspiratory pressure, the volume will be changed only. In contrast to volume controlled ventilation, the pressure will be changed, but volume will be fixed. And so constant peak inspiratory pressure, but variable tidal volume in cases of pressure control. This with surfactant, as we see, the pressure here is the same, but the volume is increased, as we see, inspiration, expiration, the volume becoming large, and so reflecting the effect, good effect of surfactant. And also in emphysematous patients, we can see this picture. This is a volume pressure group. You have to differentiate between spontaneous press on the loop and the mechanical press on the loop. As always, the spontaneous press, as we see here, starting clockwise, as you see, clockwise, but the mandatory press or ventilatory press will be started anti-clockwise. This is inspiration, expiration. This is a mandatory press. At start, the patient tries to trigger clockwise rotation, as we see, going up like this. Again, you can see this clockwise, this is spontaneous, and then the mandatory press. This is a triggering effect on for the patient on ventilator, and you can evaluate the triggering efficacy of your patient from this. Again, pressure volume loop in airway resistance. If there is inspiratory resistance or expiratory resistance, of course, it will be shifted down here like this in case of inspiratory resistance, like kinking of the tube or betting on the tube or secretions or intubation of one bronchus. Expiratory resistance, as in asthmatic patient or COPD, will give you this picture, and this loops we must be oriented with it. If we shift to we see here also in decreased compliance, the shift will be the curve compliance decrease, loop will move downward, and this angle we will see will be decreased. And in contrast to a patient with good bronchodilation or with surfactant or emphysema, the angle will be more than 45. This patient exhibiting RDS, this patient normal patient. In volume mode, we fix the volume as we see in volume pressure or in volume pressure loop, and so any effect or any bad effect on the lung will be reflected on the pressure. The pressure will increase. Here, this patient is complaining of RDS, the reddish one, and so the pressure is high to give the same volume. This is the normal one. And this patient taking some surfactant and may be improved in his compliance. This patient exhibiting over distension as we see, and so we must keep, as you know, our patient in the ideal area of pressure volume curve on the optimum area. Don't go to the over distension area or to collapsing or atelectatic area. We can diagnose some problems through our loop evaluation. As we see, there is air leak here, the expiration not going to the 0 point, and so this patient suffering from air leak. This patient may be suffering, this is a normal one. This is a normal one, inspiration, expiration. But after that, this patient suffering from insufficient flow. If you see the curve is cusping like this is insufficient flow. And so if you increase the airflow or increase or shift from volume control to pressure control. Flow volume loop again, which is used also in evaluation of pulmonary function test. We can see here the peak, this is inspiration, this is expiration, peak inspiratory flow here, peak expiratory flow. And if this patient suffering from air leak, you will find the loop changes like this. If suffering from air leak, will not going to the 0 point or function residual capacity. Also, if your patient suffering from air trapping or hyperdynamic inflation or intrinsic PEEP, this will be the picture will be changed. This is the normal one. This will elicit some intrinsic PEEP, and so the patient not the expiratory flow still there is air in the lung and there is hyperdynamic inflation. Airway secretions is typical. Also, we can be diagnosed that from the flow type, flow volume. It will be like this. The expiration will be histrations like this, septum histration. Increased airway resistance. You see scalloping here or cusping. This meaning there is some airway resistance in your patient. It's called out pattern. Also, in some patient exhibiting spasm after bronchodilator administrations, you can demonstrate the effect of your bronchodilators. You will see here the peak expiratory flow will be increased, and even the expiratory curve will be straight, not cusping or scalloped like this. There are, of course, new approaches to improving synchrony and ventilator efficacy as feedback of pressure target breath, like BRVC and volume support, which depend on tidal volume either from breath to breath or every breath, and also the smart care ventilation, which depend on feedback of end tidal CO2, minute volume, and tidal volume, and the adaptive support, which depend on feedback, minute volume, inspiratory expiratory ratio, and ventilatory work, and the novel modes, which you hear about it, professional assisted ventilation, which in a sense depend on sensing the patient flow and increased according to patient desire. And the neurally adjusted ventilator assistance, which looks like this proportional assisted ventilation and depend on the diaphragmatic picking the electric activity in the diaphragm and starting the respiration according to neuronal impulse through insertion of a catheter in the esophagus and behind the lower esophageal-gastric junction, sense the diaphragmatic spike and activate the diaphragm. And so there is a coordination between the diaphragmatic action and the brain, not the respiratory muscles. The initiating or the triggering effect of respiration here is the brain, the spike, the neural impulse, which is picked by through this catheter. Some asked about the mechanical ventilation in cardiac function. If your patient suffering from heart failure, you have to decide your patient intravascular volume is low. If low, he will be subjected to bad effect from positive intrathoracic pressure. And so if you connect your patient with hypovolemia to you, the ventilator, you may face with a great problem. The patient may suddenly arrest such starting the ventilation. And the only solution here either disconnect the ventilator or push some volume to your patient. Because the intrathoracic pressure increase in such situations will decrease the venous return, will decrease the preloading, and so will decrease the cardiac output. In contrast to patient on ventilator also, if your patient on ventilator and suffering from heart failure and he improved on the ventilator, and do you want to wean your patient from the ventilator? Heart failure patient, you want to wean him from ventilator. After improvement, you must think in some important point. Just to disconnect the ventilator, meaning you abolish the beneficial effect of the ventilator. Because the ventilator in such situations decrease afterload of the patient and decrease the congestion of the heart and the lung. And so if you disconnect suddenly your patient with heart failure after improvement from the ventilator, he may return back to a state of heart failure and suffering from pulmonary edema. Also, there is some important point for weaning your patient. And I wanted to say, don't touch the ventilator. Depend on spontaneous awakening trials daily and also spontaneous breathing trial. Try to go down with sedation during your making ground in the early morning. You have to ask the nurse, in the ICU, stop the sedation. I want to evaluate my patient and see the spontaneous, gives the patient chance to spontaneously breathing daily, and also adjustment of sedation dose and going down with sedation. Avoid diaphragmatic atrophy and avoid long time on ventilator, very bad, and also avoid too much neuromuscular blockers. For weaning, don't touch again the ventilator, just DC the sedation daily and let the patient breathe spontaneously. SAT, SBT, every one of them decrease the ventilatory days by about 2 days. Every one of them. SAT, spontaneous awakening trial, and spontaneous breathing trial. Acute respiratory distress syndrome as you know, RDS is a heterogeneous baby lung, and you have to keep your lung in this area, avoid overstretching, avoid atelectatic area. And so keep your patient here with low pressure, high volume. This is the best area on the pressure volume curve for your patient. RDS Berlin definition, it includes acute defined in 1 week within 1 week, term acute lung injury is abandoned or not used, was confusing and variably defined. We depend on PF ratio, now require a specific minimum PEEP. You have to apply PEEP 5 centimeter water. If your patient is spontaneously breathing, you can apply SPAP 5 centimeter. Change include categories of RDS less than 300 mild, less than 200 moderate, less than 100 severe RDS. Chest X-ray criteria standardized bilateral opacities, not fully explained as you know, by effusion, lobar lung collapse, or nodules. Pulmonary wedge pressure not necessary, but you evaluate your patient from the history, and if you confusing, you can make echo for your patient to exclude heart disease. Quality of survival of RDS after discharging from ICU, very important, and I wanted to send a message. Those people require a special attention post-discharge from the ICU. They are suffering from generalized weakness, pulmonary dysfunction, cognitive disability, affective disorders, and so reduce the quality of life. And so please give attention to those patients. They need a good care or a good rehabilitation care after discharge from ICU. About nasal high flow or non-invasive method for or OptiFlow for weaning of the patient from ventilator, it is a very good. It is about, we deliver about 50 to 60 liters of oxygen through nasal catheter, humidified air, and so on. And these methods it is advisable in cases of COPD and heart failure patient during weaning. It will lessen the ventilator days and may lead to success weaning of the patient. But in cases of respiratory failure, acute respiratory failure, it is not valuable as RDS patient. It mostly not valuable and may lead to more mortality. Always attach yourself to low tidal volume for all patients, even an OR patient, in operative room patient, better to use low tidal volume. High PEEP only for severe injury. Also, what do we know is good and sepsis-induced RDS? This I want to stress again on some important point. Permissive hypercapnia is grade 1. Head of bed elevated, grade 1. Don't use pulmonary catheter, grade 1. Conservative fluid in patient with RDS after he is out of shock down to CVP 4 centimeter water is grade 1. Sedation and paralysis protocol must be under protocol. Weaning protocol with SVT, very important, grade 1, and SET also grade 1. Controversial, it is the prone positioning, grade 2, recruitment maneuver, grade 2, high frequency, maybe mostly not advisable, ECMO, grade 2, routine neuromuscular blocker, grade 2 also, and you must know, neuromuscular blockade must be used for transient time, maybe 1 day, 2 days maximum. Don't use too much neuromuscular blockers, and if you use it, suspect your patient needs more sedation and good sedation because he is awake and he is, it is not a sedative drug. Ventilator management of acute respiratory failure, low tidal volume again, PEEP only and low PF ratio. Don't support high frequency or steroids. Neuromuscular blockers must be used as little as you can. Pulmonary artery catheters not so indicated. Dry lung, very important. And when we say dry lung, even under diuretics, we meaning CVB less than 4 centimeter water, but also you have to give attention to the renal functions, otherwise the patient may be develop acute renal injury. So you must compromise this situation. Steroid only in day 7 to 14 may decrease the inflammation and the fibrosis. Also, non-invasive positive pressure ventilation. Tracheostomy not decreasing the the mortality or decreasing the ventilator days, but it decreases the doses of sedation, and that I think it will facilitate the process of weaning, and also it is comfortable for the patient. Non-invasive ventilation in COPD and congestive heart failure. Don't use non-invasive ventilation in respiratory arrest, in medically unstable patient, in a patient unable to protect airway, in patient with excessive secretions, in uncooperative or agitated patients unable to fit the mask, recent upper airway or gastrointestinal surgery. Try to avoid non-invasive. This summarizes the scenario which we must follow as we see from starting from mild RDS to severe RDS, low tidal volume in all grades, low moderate beep in the early situation of RDS, high beep in severe RDS. Non-invasive ventilations may be used in all the yellow pictures. It is controversial. Prone positioning if the PF ratio less than 150, ECMO, external or extracorporeal carbon dioxide removal indicated, high frequency, grade 2 as I said, and not so indicated, not so efficient or beneficial. Thanks for you for your attention.
Prof Khalda? Prof Khalda Radwan? Hello? Dr. Huda?
Time optimum, Dr. Saad, or
no, that's fine, sir. Just I'm trying to call Professor Khalda Radwan and Dr. Huda.
Yes. Thank you, Dr. Samir, very much for your lecture. I really enjoyed it. It's very rich.
Dr. Khalda is here now.
Merci. Allah يخليك دكتور سعد. Many thanks, Dr. Samir, for your wonderful always يعني simplifying very difficult topics الحقيقة و complicated topics. I think it is very difficult all students or colleagues even to understand. You make it very easy, very easy. I hope if we always يعني very honored to have Dr. Samir with us. He is an eminent professor at intensive care in Shams University. We need if any questions is applied for Dr. Samir to answer, inshallah.
Actually, there is no question at the moment, so we can move